All right, so we're going to start talking about antiarrhythmic drugs, starting with class ones. So, class ones are drugs that inhibit sodium influx. The three names of the drugs under this class are lidocaine, quinidine, and procainamide. The mode of action is to inhibit the sodium influx into the myocardial cells that will slow down the um, automaticity of the cell and allow the normal rhythm to take over. So the SA node and the AV node, the sodium influx is not inhibited in them. They are the ones that are able to maintain the proper rhythm in the heart. So it's just slowing down any ectopic foci from firing. So the first one that we're going to talk about is lidocaine, and this is one that if you watch medical shows focusing on the emergency room, you'll hear them shout lidocaine stat, and it's for an arrhythmia for their patient that has suffered some kind of trauma, and their heart is um, potentially sending out those premature ventricular contractions and a series of them. And so we need to treat them. So this is what we use to treat them. So this drug, lidocaine, is not absorbed well from the gastrointestinal system. So we do not give it in any form except for IV. That is the most effective way to treat an arrhythmia. And we can give it as boluses. So they'll say lidocaine bolus stat, or you add lidocaine to a bag of fluids, and that's known as a constant rate infusion. You're giving it at a certain rate together with some fluids to help support the animal's cardiovascular system. If we need to send that animal home to treat this condition, then we're going to use mexiletine. This drug is absorbed orally very well, and so that is what we'll send them home with. So lidocaine is used to treat ventricular arrhythmias. It does not do well for atrial or supraventricular arrhythmias. So simply the arrhythmias that originate from ectopic foci in the ventricles. That is what we use lidocaine to treat. We want to be very careful in using lidocaine in cats. Some practitioners will not use it in cats at all. The cats just seem to be more susceptible to the toxicities. So what we'll see at low dose intoxication is sedation, ataxia. Ataxia is basically stumbling in coordination of movement, and drowsiness. So they kind of act drunk, I guess, is the way that you might want to talk about it. But so we get that sedation and drowsiness and kind of moving funny. At high doses, we get the opposite. We start to get central nervous system stimulation, and it can progress to seizuring. It is a drug that's very rapidly metabolized. So if an animal is seizuring, we don't really have to treat that. We usually just wait for it to stop because the metabolism is so fast. We're giving it, remember, we're giving the lidocaine IV. And then but the cardiovascular depression that we can get from some of these other types of antiarrhythmic drugs is less with lidocaine. So it doesn't tend to do that. We just need to watch for these other toxicities and avoid that. Something very important to know about lidocaine, and I did talk about earlier, I talked about epinephrine and how we put epinephrine in with lidocaine. So it's really important to know that there are two types of lidocaine you're going to have in your clinic. Okay, one associated with this toe. Sorry, it's a human toe. But I was looking for a picture of lidocaine, and this is the brand name xylocaine. And it just happened to come with the toe. And the toe will remind you that this is the type that we use as a local anesthetic, and we don't use it to treat arrhythmias. So this local anesthetic should be kept in a separate area from the antiarrhythmic treatment. Maybe put a piece of tape on it, or in some way, it should be in a different location from, like your crash cart would be the place to have the lidocaine that you're treating arrhythmias for. Your treatment area where you're doing procedures under a local anesthetic. Not to say you can't give a local anesthetic during a surgery, but you want to have this in a different place from some place that you would reach for emergency drugs. So the reason for this is that it is lidocaine packaged with, or included in the lidocaine is epinephrine. Epinephrine is the neurotransmitter of the sympathetic nervous system. If you were to give this as a treatment IV for a ventricular arrhythmia, you're going to cause overstimulation of the heart. And if you have a real problem with that heart, that could lead to death. So you definitely want to have a way to mark this. The reason why we have the epinephrine together with the lidocaine is that epinephrine acts on the alpha 1 receptors that then cause constriction of blood vessels, of superficial blood vessels. So if you have that lidocaine, which is the local anesthetic, that's what we use it for in this situation, and you inject it in the toe to treat the toe, it's going to make that lidocaine stay there longer because you've constricted the blood vessels locally. So that's the whole idea with that. It's just that you need to remember there are two types of lidocaine, and you do not want to use the type that is used as a local anesthetic for treating heart arrhythmias. So the other two drugs in this class 1, the sodium influx inhibitors, are procainamide and quinidine. These have come to be used less in veterinary medicine, in part because they're not used as much in human medicine. So they're not as available as they once were. Whoops, I'm sorry. I'm trying to bring that down, my little box down so that you can read the bottom better. So they're similar to lidocaine, but they are effective against atrial fibrillation and flutter, as well as ventricular ectopic foci. So wherever it originates in the heart, these can be used. Procainamide is the one that we sometimes see in small animal medicine. Quinidine is the one that's used in horses to treat atrial fibrillation or flutter. It has a kind of, your book goes into a longer explanation. You don't need to memorize that, but it will not necessarily, when we treat horses with quinidine, it doesn't necessarily bring their heart rate down, but it will make the pattern, electrical pattern, more regular, and the heart will fire more effectively. So I also will make the notice that you may have heard of quinidine. Quinidine is used to treat malaria. It is the same drug that is used to treat malaria in some parts of the world where we have malaria. But those two, procainamide and quinidine, are the ones that get used as well as lidocaine. And we can treat the atrial arrhythmias. So beta blockers, these are the class 2 types of antiarrhythmics. And you'll see that they are in a family that has a similarity of names. They end in LOL. If you think of laughing out loud and blocking the beta, I don't know how you want to think of it, but the names are propranolol, atenolol, esmolol, metoprolol, carvedilol. So LOL is a beta blocker. So what happens in a heart that is weakened for a long period of time, or for a while, I shouldn't say for a real long period of time, but for a while, is that the body's sympathetic nervous system will take over to try to make that heart beat more effectively. So if we have the weakened, diseased heart and it's just not beating effectively, the sympathetic nervous system sends out epinephrine and norepinephrine in order to stimulate it. It will eventually make that heart more electrically unstable. We'll start to get ectopic foci and arrhythmias. So um, these drugs are going to help slow the heart down and slow that force of contraction. And drugs that do that are called negative inotropic drugs. Inotropic has to do with the force of contraction. So they're acting negatively on that force of contraction. And so we're going to slow the heart down. That's our goal with these beta blockers. So the first one I'm going to talk about is one we don't use as much anymore, and you'll find out why. It's called propranolol. The trade name is Inderal. And this one, um, the way that these beta blocker works, they work on the receptors and they block epinephrine and norepinephrine, remember, that are released in the response to the sympathetic nervous stimulation, wanting the heart to beat faster. Um, and they block those receptors. The thing about propranolol is it blocks both beta 1s, which, if you remember, control heart rate and contraction, force of contraction, as well as beta 2s, which control the bronchioles. And that they're on the bronchioles, and what they do would normally be to dilate the bronchioles. So if they block those receptors, it's going to cause reflex bronchoconstriction. And in an animal that's having a hard time getting the blood around, the blood carries the oxygen. We don't want to decrease their oxygenation any further. So that's not a very desirable effect. But propranolol was what we had for many years. But now we have the newer beta blockers. Again, they end in LOL, just like propranolol, but they are carvedilol, metoprolol, atenolol, and esmolol. And these are superior to propranolol in that they are selective for the beta 1 receptors, the ones that are going to control the rate and the force of contraction. They do, with that blocking action, they allow parasympathetic dominance of the heart, and especially in the area of the SA and AV node. With too much of these drugs, we can get a lack of conduction between the SA and the AV node. That's going to, what it's going to show up as is a decreasing heart rate, an increase in that PR segment on the ECG, and it can lead to AV block. AV block is a blockage between the transmission of the signal between the atria and the ventricles. And that results in a missed heartbeat. We might see a P wave without a QRS wave. And I don't have a diagram of it here, but I will show you it in a further along in talking about another drug. So we need to be careful of that because we don't want to miss heartbeats. Something that can happen and might push us to increase the dose of this drug is that there's a resistance that occurs with beta blockers. And what happens with long-term use is the myocardial cells begin to recognize they're not being stimulated, and they do what's called upregulation. They actually put out more receptors on their surface. This increase in receptors causes the dose that you initially start with to appear less effective because there's more receptors, but there's less drug. There's the same amount of drug to block what were the initial receptors. If we increase, eventually there will the dose, eventually there will be a stabilization in this, but we stand the chance of having AV block. Remember that from the slide, the previous slide. So we don't want to go too far down the road of increasing these beta blockers. In the long term, we don't want to discontinue beta blockers suddenly. This is a lot like steroids, but a very different reason. It simply has to do with an increase of these receptors is going to cause overstimulation if we take an animal off the drug suddenly. We need to taper these off over a several weeks or so. So the thing about beta blockers is it's a balancing act. In a heart that is failing, that has a lot of muscle weakness, this can decrease the heart rate too much. And so it can be difficult. The veterinarian has to decide between treating the arrhythmia or treating the heart failure. And it's a balancing act sometimes with these drugs.